HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
I will be speaking to Dr. Alessandro Fois on Parkinson's disease and its diagnosis. Dr. Fois, tell us about yourself.
Thanks for having me on, David. So I'm a neurologist based out of Sydney. I work at Macquarie University Hospital and also in my private practices in North Sydney and at the Woolcock Institute in Glebe. And I also do a visiting neurologist service to Hervey Bay in Queensland, a regional clinic where I do face-to-face clinics and telehealth. My clinical and research interests are mainly in movement disorders like Parkinson's disease and tremor. And I'm also very interested in telehealth and its expanding role in lengthening the reach of neurological care throughout Australia.
Alex, today we're actually going to just look at Parkinson's disease. So I've got two opening questions for you. The first is it something that we need to worry about because it's increasing in incidence, or is it decreasing in incidence? Question one. And the second is, how can a GP diagnose Parkinson's disease?
So to go to your first question, David, I think the data are telling us that Parkinson's disease is increasing in incidence. So we're seeing more and more Parkinson's disease as time goes on. What remains a bit more of an open question is, does that just reflect the aging of our population, especially in a country like Australia, where the population pyramid is becoming more and more populated by people in their 70s, 80s, and 90s as we live longer? Because we know that age is a risk factor for the development of Parkinson's disease. Or is there something else going on that's actually driving an increased incidence of Parkinson's disease, even when we control for age? So that remains a bit more of an open question from my reading of the literature, but there's certainly no doubt about the fact that we're seeing more and more people every year diagnosed with Parkinson's disease.
Before we move to the second, I've got a question here. Are we seeing younger people with it?
That's a good question. So first of all, just to touch on young onset Parkinson's disease, because it's something your listeners may not have seen a lot of. First of all, about 25% of patients will have the onset of Parkinson's disease before the age of 65. And I think it's somewhere about 5 to 10% of patients under the age of 50. Wow. So there is a subset of patients where they'll have the onset of Parkinson's very young. The youngest I've seen is around 18, 19, and that's because I'm an adult neurologist. And these very young onset cases often have an underlying monogenic or genetic cause. And probably the youngest I look after at the moment had onset in their 30s. So there is a subset of patients who develop young onset Parkinson's disease, often, but not always, of genetic cause. Whether or not the incidence is going up, I think, is less clear. I mean, it's a smaller cohort, if you like, of patients with Parkinson's disease. And the other factor is that we're learning more and more about the genetics of Parkinson's as well, which influences our understanding of this sort of young onset Parkinson's disease cohort.
Now, this allows me to be a little bit more nuanced with my second question. Now that we are seeing a larger age range of patients who may present with Parkinson's, maybe as a GP, when should we be alert to even asking the question about Parkinson's disease when patients come in their 50s, 60s, and 70s?
I can reframe that a little bit by just talking through the diagnostic criteria for Parkinson's and how do we achieve the diagnosis. And let me start off by saying it remains largely a clinical diagnosis. There are some new and exciting diagnostic tests, and we might get into that later as well, but still, generally speaking, we make the diagnosis clinically based on the symptoms and the physical examination findings. And the key elements to Parkinson's and this is sort of medical school refresher, is the patient must have bradykinesia and either rigidity or rest tremor. And then there are some other sort of supporting criteria that can be used to narrow down from that broader definition of Parkinsonism down to, is this typical idiopathic Parkinson's disease? So just to go in, but to give a bit more nuance and a bit more of a clinical flavor of how might the patient sort of walk into clinic. So let me talk about tremor first of all. The tremor of Parkinson's, I mean, the first red flag for me is it's typically quite asymmetrical. So people with Parkinson's will typically notice the tremor just in one hand at the onset, and often on the examination in the clinic, they'll have it just in one hand, or at least quite asymmetrically, much more prominent in one hand than the other. And that is a really useful diagnostic tool to contrast from the other common cause of tremor, which is essential tremor, where the tremor is often much more symmetrical and will have onset affecting both hands. But the other facet of the Parkinson's tremor that's striking in the clinic is that it's present more at rest and more when the patient walks. That's the other, those are the two conditions that really bring out Parkinson's tremor, in contrast to essential tremor, which is more when people are using their hands. So I reflect on this sometimes when I read the referral letters I get, and oftentimes I think to myself, oh, this is definitely going to be Parkinson's. And one of the red herrings in the first line of the referral I get is, could you please see this patient who's noticed tremor in the right hand for the last few months, or tremor in the left hand for the last few months? And I think, one-sided tremor, it's looking, the suspicion for Parkinson's goes up a lot. But the second phenotype, if you like, of Parkinson's, or the second way it presents, is more with stiffness and slowness of movement. And the way that often presents in the clinic is, and I think back to the referral letters that I receive, is a patient noticing one arm or one leg just not working quite right. And so they might say they've noticed their arms become stiff or clumsy, and they've noticed problems with their writing, for example, or sometimes the partner notices a loss of arm swing on one side, or if it's lower limb bradykinesia or stiffness that's bringing the patient to see the doctor, they might notice that they're dragging one leg, and that's a typical presenting complaint. So these are some of the symptoms, some of the sort of motor symptoms, if you like, the symptoms related to movement that the patient might flag to the doctor in the consulting room that can raise a suspicion of Parkinson's. The other thing I would say is that alongside the motor symptoms, we're increasingly recognizing that there's a Parkinson's prodrome that starts even years or up to a decade before the patient starts to develop some of these movement-related symptoms like tremor, stiffness, or slowness. And that prodrome includes a number of symptoms. So things like constipation, which is very, very common in Parkinson's, loss of sense of smell or anosmia, and also this very interesting phenomenon of dream enactment or REM sleep behavior disorder. So this is a really interesting phenomenon where, and often the patient's bed partner will describe it best, where while the patient is asleep and dreaming, they call out in their sleep, scream out, punch their bed partner in their sleep, or throw themselves out of bed. And if you drill into this in a bit more detail with the patient, they're often dreaming about something frightening, like they're fighting off attackers, or sometimes they're having a sporting related dream. And I have patients tell me that they marked the bedside lamp or something of that because they were dreaming about sport. And the significance of this phenomenon, this REM sleep behavior disorder, where they act out their dream, is that it's actually highly specific for developing a synuclein-related brain disease like Parkinson's or multiple system atrophy or dementia with Lewy bodies, within 10 years.
Wow.
So oftentimes when you see your patient in the clinic with tremor in one hand or stiffness or slowness in one arm or one leg, you might get this history in terms of their sleep behavior that even for years before, they've been acting out their dreams, throwing themselves out of bed. And that's actually quite a specific clinical feature pointing towards a synuclein disease like Parkinson's disease.
I'm going to make a connection here, Alex, because I have spoken with many sleep physicians in the past, and we had looked at REM sleep disorders and discussed it. But I did ask myself, why are you working at the Woolcott Sleep Institute? Now I realize this incredible connection between REM sleep disorders and various forms of neurodegenerative diseases that we have to be aware of. It's not just something you give them some clonazepam or something and hope it disappears. We actually need to keep an eye on them. Now, I just need to ask one more question before we move on. With the onset of constipation, you had mentioned that there may be other causes that is still not clear because the evidence is not quite there. Are we getting the sense that maybe some kind of bowel microbiome issue might be afoot here?
Yeah, look, it's a fascinating question, and it's a really rich vein of research in Parkinson's. This idea that the gut is maybe the initial site of where the Parkinson starts. And there's a lot of evidence pointing us towards this idea. And in particular, there's some pathologists who have discovered actually we can find the synuclein protein, this protein that misfolds in the brain and causes the Parkinson's disease. We can even find aggregates of this synuclein protein in the enteric nervous system, in the gut. And people have done very fascinating experiments in animals where they have injected synuclein fibrils into the gut and then observed that the misfolding of the synuclein has spread to the brain. And they've even done studies where they've done that to the same animal, but done a vagotomy and ligated the vagus nerve and found that it doesn't spread to the brain.
Oh.
And people have then followed that up in humans and actually had a look at subsets of the population, particularly in Scandinavia, where they have these registries, and they can look at people who have had a truncal vagotomy for treatment of peptic ulceration, was used decades ago to treat acid secretion. And these people have had a truncal vagotomy. If you follow them up over 20 years, they're at a lower risk of developing Parkinson's disease. So there's some really fascinating evidence to support this hypothesis that maybe the origins of the Parkinson's are originally in the gut and then spread over years or decades to the brain. And people are thinking more and more about, okay, how can we translate that into treatment? Is there scope for using probiotics to try and modify Parkinson's risk? Is there scope for using things like fecal transplantation? And this is all in the research space, and it's obviously a really difficult thing to study, because if you're trying to explore how you can modify risk years or decades before the Parkinson's starts, then that's going to take a long time. But we're making more and more progress with developing biomarkers for Parkinson's so that we can sort of try and stratify people's risk and identify, prodromal Parkinson's even before the symptoms emerge. So there's more and more scope to try and study these kind of tricky questions as time goes on.
Thank you for that, because two things. One is that I really wasn't very aware of the prodrome, and it's really interesting that we can now ask those questions once they present with some, if you like, more typical symptoms. The second question.
Yeah, and just to jump in, actually, David, just on that topic, I mean, the constipation is so common in Parkinson's. It's one of these things that I ask every patient about every visit, because A, it can cause problem in its own right, and you see the occasional patient where they wind up in hospital with fecal impaction, and B, sometimes if there's severe constipation, it can actually interfere with the absorption of the oral medications, and be a potential cause of why the Parkinson symptoms are not under good control. So I think it's a really important thing to screen for.
My goodness, I never even thought about that, Alex. One question, do you also assess their mental health and cognition?
Yes, yeah, I'm really big on this, David, and but I think it's something to put into context as well. So first of all, the data tell us, and actually some of this data is from Sydney. In fact, there was a big study a couple of decades ago using Sydney Parkinson's patients exploring the risk of dementia, and there've been other studies too. And overall, the risk of dementia and Parkinson's seems to be around about 30%. After 10 years of disease. The Sydney study estimated it higher than that, but looking at studies across the world, it seems to be around that sort of 30% mark after 10 years of disease. And so the first thing to say is that dementia is uncommon early on in Parkinson's. So it'd be an unusual early feature within the first year or two of disease and might point towards an alternative diagnosis. But it is relatively common as time goes on. And so it's something that I often don't try and tackle in the very first visit when I'm perhaps giving someone a new clinical diagnosis of Parkinson's, initiating them a new treatment, working through all of that conversation. But it is something I screen for as time goes on. And oftentimes, I try to just do the cognitive testing, whether that's with an MMSE or a MOCA, because I find oftentimes you find a lot of mild cognitive or even worse cognitive impairment by actually testing the cognition than you do just by asking about the symptoms. Patients can present very, very well, but actually have underlying cognitive impairment, which might need to be addressed with lifestyle interventions or with medication, and might have impact on their fitness to drive as well. So I have a very low threshold for testing cognition formally in patients with Parkinson's, and it's something I think is worth doing on a regular basis, especially as time goes on.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
And what about the incidence of depression?
Depression is also very, very common, and it's another one of these, what we call non-motor symptoms of Parkinson's, so symptoms not related to movement. So depression, anosmia, the REM sleep behavior disorder. But depression is very, very common, and it's something that is in some ways logical, because the dopamine system, which is affected in Parkinson's, is not just involved in regulation of movement, but also regulation of mood through the limbic system. And we wind up giving patients lots of dopamine stimulating medications as well. And so the depression is very, very common, I think is also worth screening for. And one of the interesting things about trying to help patients with Parkinson's improve their quality of life is that in the first year or two, early on in the Parkinson's, people seem to get the most benefit out of treating their motor symptoms, their tremor, their stiffness and slowness. But actually, after a few years of Parkinson's, it's these non-motor symptoms like depression or cognitive impairment that have the most impact on people's quality of life. So I think it's important to remember, if you see someone in clinic where they've had the Parkinson's 5 or 10 years, maybe they feel like they find it very difficult to move and the dopamine medications aren't giving them the relief they would like. There are still things we can do to help them through addressing these non-motor symptoms, like depression or the constipation, for instance, that can improve their quality of life. So I think it's a very important thing to screen for and address. There's no particular, in terms of treatment, the treatment I think is very standard. There have been a few more studies for SNRIs like venlafaxine, and so that's often a sort of early go-to medication for me. But equally, I think using SSRI medications is also very reasonable where medications are needed. And of course, the the psychological treatment and physical exercise remain very important treatment modalities. And actually, the one other comment I just want to make about depression is that you see some patients where it's actually a sort of fluctuating symptom that's associated with the wearing off of their dopamine medication.
Okay.
So you might see a patient who's taking Parkinson or Matapar, levodopa 3 or 4 times a day. And sometimes when that medication wears off before their next dose, they might get slowness, stiffness, tremor, their Parkinson's symptoms are re-emerging, but they might also feel really depressed and anxious as part of that wearing off phenomenon, as that dopamine level in the brain is falling below the critical threshold for them. And so one thing I always think about when I see someone with Parkinson's who's struggling with depression is, have I got them adequately treated in terms of their dopaminergic therapy? So I think that's another useful consideration.
Alex, I need to tell you, I love the way you're taking us through it. It's very nuanced, it's very practical, and I really am enjoying this tremendously. We're coming now to the patient giving us a story, and when we see them, we suspect that they have Parkinson's. The time is now for physical examination and possible investigations before we even think about referral. So can you take us through some of the critical physical examinations?
Yeah, sure. So the first thing on, or let's say the key thing on physical exam is to assess these motoric, or these key motoric features of the Parkinson's, the bradykinesia, rigidity, and tremor. But actually, let me even just take a step back from that and just talk about, seeing the patient in the waiting room, because often, and you hear about all this in the medical textbooks and lectures, but often the diagnosis reveals itself as they get up from their chair and walk into your office. And observing that hypomimia, that loss of facial expression, and the loss of arm swing, which is often unilateral, often just on one side, these are really useful clinical markers even before they get into your room. And in inspecting that arm that's not swinging properly for, is there any tremor when they walk, is often a really useful clue as well. So there's a lot of clues there as they walk in. One other thing I just want to say about the hypomimia and hypophonia is, this was something that really baffled me in medical school. I remember being a medical student and seeing a patient with the consultant neurologist, and they'd say, can't you see how reduced their facial expression is? And I used to think to myself, it doesn't look that unusual to me. I really don't understand this. And the more patients you see, the more I think you come to appreciate some of this nuance of the facial expression, and things that you see written down, like the reduced blink rate and slower movements of the face. But I think a really useful kind of trick that I found useful as I went through my neurological training was actually to just compare their face with their partner. And the partners are sort of sometimes a roughly age match control. And oftentimes you'll have 2 people in your office who are 70 something, and the patient who's seeing you about the tremor really looks very flat, and the partner might have a very kind of animated voice and facial expression. You think, yeah, there is some hypomimia and hypophonia in the patient. But then in terms of examining these cardinal features of the bradykinesia, tremor, and rigidity, so the slowness of movement I assess with the finger tapping and foot tapping. I get the patient to, and the finger taps are the main thing, so to get the patient to tap their thumb and index finger really big and fast. And again, there's so much variation in the normal population about how fast is normal for tapping your thumb and index finger together. Again, I find it really useful to just compare it side to side, because we expect Parkinson's to be quite asymmetrical. And so often, especially let's say the patient comes in with a tremor in their right hand, and then you check for the finger taps and you think, oh, actually that tremulous hand, the taps are slower than the other side. Again, that's another clue when you're putting the pieces of the puzzle together. So the finger taps are, I think, the main tool for assessing the bradykinesia. But, again, in a little bit more nuance, sometimes you'll just find patients will, that slow hand, they just won't use it as easily as the other hand. You get them to lift their arms up and there's just a little bit of lag with the slower hand. And one thing I particularly notice in these COVID days is, let's say a right hand dominant patient who's come in to see me with right hand tremor, they go to adjust their mask and they'll do it with their left hand. Or they go to get their phone out and they'll do it with their left hand. And you think, that right hand's not working quite properly, is it? There's a bit of bradykinesia there that's influencing the patient's hand choice. So these are some of the subtle things that you can look out for the bradykinesia as well. The tremor we've talked about for Parkinson's is mainly a rest tremor. So I think the main thing for examining it is seeing the patient with their hands in their lap. And I'll sometimes distract them as well, get them to count backwards, or say the months of the year backwards is a good one to mentally distract them. And that can bring out the tremor, amplify the rest tremor as they relax with their arms in their lap. And also looking for the tremor when they walk. That's the other thing that really brings out the Parkinson's tremor. And similarly with the stiffness or rigidity when you're checking the tone in the arms and legs, the other trick that can really bring it out is, again, distracting the patient. So I might get them to tap the other hand. Let's say I'm examining the right arm, I'll get them to use their left arm to tap on their thigh to try and bring out that rigidity. And that's another trick to try and detect subtle rigidity. So those are the sorts of ways of looking into these cardinal features. But I think the gait examination and looking at the face and hearing the voice are very, very important. And the other trick I want to just mention with examining the walking is just to pay, in addition to looking for the loss of arm swing, maybe a stooped posture, maybe taking a little bit more time to get up from the chair. But the other trick is just count the number of steps it takes them to turn 180 degrees. I often just count it and document it in my notes, because normally people spin when they turn 180 degrees. They'll just spin on one foot and turn in a single step, or maybe 2 steps at most. Whereas often with Parkinson's, people will take 3 or 4 or more steps to turn 180 degrees. And it's not something that strikes us too obviously to the eye unless we really pay attention to it and count it. So that can be another helpful trick for observing the abnormality of the gaze.
I am amazed how time flies. When I was a young student, cogwheel rigidity and the blepharospasm seemed to be really right up there. You haven't even mentioned it.
Yeah, so the cogwheel rigidity is, thank you for bringing that up because I didn't quite flesh it out. That's the particular pattern we're looking for when we examine stiffness in the tone, is looking for not just stiffness, but this kind of cogwheel pattern where, especially when we're examining the wrist, it might sort of ratchet around. So thanks for clarifying that. And then the glabella tap's an interesting one. I must say I don't do it much these days, not because it is not abnormal. I mean, and just to take a step back, we're talking about the glabella tap, this maneuver of tapping the patient in between the eyes and observing for reflexive blinking. The patient should blink. And normally when you do this to a healthy control patient, they'll blink a few times as you tap steadily between the eyes and then will fatigue. Mm-hmm. But in Parkinson's disease, they'll keep blinking, and that's as you tap, and that's a positive glabella tap. But the reason I don't do it much these days is because it's just not a very specific neurological sign. So it's positive in Parkinson's disease, but it's positive in other neurological conditions as well. And so because it doesn't have a high specificity, that's the reason I don't do it routinely.
At this point, having examined the patient, the probability for Parkinson's disease is right up there now. Do we as GPs initiate any blood tests or any other investigations before we consider referral? Are you going to suggest that we refer patients earlier or later?
I think it's absolutely fine to refer patients after the initial physical examination, with or without further testing. And the tests that I do, let's say if a patient comes to me with a new diagnosis of Parkinson's without any investigations done, the test that I'll typically do would be an MRI of the brain. And I'll tell the patient that we're doing this actually more to rule out mimics of the Parkinson's disease. So things like normal pressure hydrocephalus, where there's increased fluid within the ventricles and that can cause Parkinsonism, or indeed things like multiple system atrophy or progressive supranuclear palsy, PSP. Sometimes we see features of that on MRI. There have been research studies using MRI to look really closely at the substantia nigra and actually use that to diagnose Parkinson's disease. But from my reading of those studies, they're usually using special sequences and sort of stronger MRI techniques, 7 Tesla MRI. And so I don't think it's something, my feel is it's not a clinical, not a radiological sign we can reliably look for on just a standard MRI that we would do in clinic in Australia. So I would do an MRI brain mainly to exclude mimics of Parkinson's disease. And then in terms of blood tests, there isn't any very specific part of the workup, but if I have a young patient, I'll typically check their copper and ceruloplasmin levels to test for Wilson's disease, which is a very rare mimic of Parkinson's. And if I have a patient who has tremor as the main symptom, I'll typically check their thyroid function and just make sure they're not also hyperthyroid. But I'm very happy seeing these patients without any investigations. And actually in the telehealth world, because I will see some patients from, particularly in my Queensland clinic, where they might be from, a town 300 kilometers away from Hervey Bay where I practice. And the diagnosis of Parkinson's might be very obvious through the telehealth, through observing them walk, seeing their tremor, seeing their bradykinesia. And, I'm happy giving them that diagnosis and initiating treatment via the telehealth while we're doing other investigations. And I know of others, other sort of international leaders who have also written position pieces about telehealth diagnosis in Parkinson's, who are also comfortable with that approach, especially where it can be very difficult to organize a face-to-face meeting. So I think MRI is the main basic test. There are more dedicated tests we can do now to confirm a clinical diagnosis of Parkinson's, but accessing them in Australia, there are some barriers. I think it's worth knowing about, though, because patients might ask for it. So there's a type of scan called a dopamine uptake scan, or DAT scan, where the patient is injected with a radioactive dye that's taken up by the dopaminergic areas of the brain, so in particular the striatum. And it's the best radiological test or class of test we can do to diagnose Parkinson's disease. It's not specific for Parkinson's versus, let's say, mimics of Parkinson's like PSP or MSA, but it is very good at distinguishing Parkinson's from healthy control or from essential tremor. In Australia, it's historically been difficult to access, but it's actually becoming more and more widespread. So there are centres in Melbourne, Sydney, Brisbane, Sunshine Coast that can do this kind of scan, but it's not yet covered by a Medicare rebate. There has been a recommendation from one of the MBS review bodies recommending an item number be added for one of these types of scan, F-DOPA PET scan, but that was some years back, and I think it hasn't yet percolated through the system. So it's a useful test, I find, for a small subset of patients where the diagnosis is unclear, or also patients where, they've seen 4 neurologists, everyone's had a different idea of the diagnosis. And even though I think it's clearly Parkinson's, I recognize that they've been on this journey and they just want to have some certainty. So I think there's a subset of patients who can benefit from this additional diagnostic scan, the DAT or DAT scan, but for the majority of patients I see, they wouldn't have it and don't need it.
Now, Alex, that was a very important discussion we've had about diagnosis, the natural history, and also, if you like, the examination and referral of the patient with Parkinson's disease. What are your key messages to our listeners?
I guess my first comment would be, I've unpacked a lot of detail about the diagnosis of the Parkinson's, and I know, practically speaking, my wife's a GP. I totally get it that when you've got a very busy list of patients in primary care, it's difficult to unpack a lot of that detail. And so the real highlights I would give from the history and the physical examination would be, first of all, just being attuned to the asymmetry of clinical symptoms and signs. So the patient with a really asymmetrical tremor or really asymmetrical stiffness or slowness in an arm or a leg is often a highlight for Parkinson's. And then also for new patients and also your ongoing patients with Parkinson's, being attuned to those non-motor symptoms. So those things like depression, constipation, anxiety, which are very, very common in Parkinson's, and where I think, as a neurologist, I think our primary care colleagues are a really important part of managing that part of the patient's overall health.
Dr. Fois, I thank you for that. That's really helpful. What a wonderful, wonderful talk. Thank you.
Thank you.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.